Garcia, we're going to move forward to the STRIDE study suggests race, not sex, is associated with outcomes in acute limb ischemia treated with mechanical aspiration thrombectomy by Dr. Alex Powell.
Thank you to this esteemed panel, and thank you to the audience for sticking with us as the night gets old and the election results start coming in. So we're going to be continuing kind of the same theme as what we heard before here, and as you can see in the title, we'll be looking at both race as well as sex and the outcomes of the STRIDE trial. I'm pleased to present this on behalf of my co-authors. Tom Maldonado was the PI for this trial here. So let's set the stage a little bit. What is the STRIDE trial? Well, the STRIDE trial was a multi-center trial looking at the effects and the safety and efficacy of the indigo aspiration system for those patients who are presenting with acute limb ischemia. It was multi-center, 16 sites, 13 in the US, 3 in Europe, 119 patients, and you can see, which we're pleased to talk about, is the fact that there was a very healthy percentage of women enrolled in this trial, nearly 50%. The primary safety endpoint was target limb salvage at 30 days, and that was the basis for the original set of publications in JVS. And we'll be looking at those 30 days, but we'll also be looking at some of the 365-day both primary and secondary outpoints, and those secondary endpoints include technical success, patency, TLS, major bleeding, and mortality. Okay. To be enrolled in this trial, you had to have symptoms lasting less than 14 days. Rutherford 1, 2A, or 2B scores were allowable. First-line treatment had to be with the indigo aspiration system, and it was up to the operator if they wanted to use lytics as an adjunct. As you can imagine, it had to be over 18 years of age. Small vessels were excluded, kind of the standard exclusion criteria, and notably bypass grafts that were synthetic were allowed, but not saphenous vein bypass grafts here. So again, we can just skip through that. Looking at some of the demographics, again, we see the large percentage of women enrolled in the trial. Age range was 66%, median age was 66 years. The medical history, as you can imagine, many of these patients had the risk factors that we anticipate. I'll just point out that 20% of patients had atrial fibrillation, and a very high percentage, 53%, had previous treatment in the affected limb. So kind of an at-risk population that we're looking at. If we look at the Rutherford classification upon presentation, the majority were 2A and 2B. And if we look comparing the men to women enrolled, there was no difference in the class upon presentation. Thrombus length was relatively decent at 12.5 centimeters diameter, as you'd expect, and predominantly a femoral popliteal segment was 5.4 centimeters here. Again, no difference in the men and women in terms of the baseline characteristics. Blood loss less than 400 was encountered in the majority of patients here. Interestingly, and this is something that we'd like to change, 30% of patients had a stay in the ICU with an average length of stay of 2.5 days. I would argue that we can improve upon that significantly. In terms of the use of adjunctive lytics, 20% of patients in this trial ended up undergoing overnight lysis. Another 20% of patients had some form of on-the-table lysis, so that equates to 60% of patients underwent aspiration alone, no use of lytics here. So let's look at those 30-day outcomes here. Target limb salvage at 30 days, all comers, 98%, very high target limb salvage. And again, we're going to keep switching back and forth to the categories of looking at females versus male. No difference in target limb salvage. Technical success, patency, improved quality of life surveys. Again, no statistical significance between the female and male populations here. Safety at 30 days. Again, no statistical significance. I do want to stop on the major bleeding for just a second because this may be somewhat unique to women, although not necessarily. The reason that there was a larger percentage of women that had what was defined as major bleeding was the criteria of a transfusion of more than 2 units. And if we look further at that group of women who received those transfusions, more than 2 units, the majority of them presented with anemia at baseline. None of them had a retroperitoneal hemorrhage or access site complication, but that's why we see that higher incidence of bleeding. Again, not statistically significant, but it's approaching that and is worthy of commentary here. At 365 days, now this is the new data, again looking at target limb salvage, all comers 88%. Interestingly, in women, that number is higher than men, but again, not statistically significant. Mortality at 365 days, slightly higher in women than men, but again, the same theme again and again. There is no statistical significance in the outcome looking at the 365 data comparing men to women populations here. Quality of life scores were significantly improved to the point of significance in 76% of patients, and again, no difference in men as compared to women. So again, we can see no matter how we're really looking at this, there's no significant difference in these outcomes, the safety, comparing men to women. Now, if I were to say there's one important slide in this whole talk, it's this talk, which is a further analysis of different baseline risk factors or different baseline risk characteristics. And if we look at the African American population, this is where we start to see some really startling differences in this outcome here. If we look at the hazard ratio of undergoing an amputation, if you're an African American that presents in this case, the hazard ratio is 13.2, astounding. The p-value is obviously significant. There were 10 total amputations in this entire trial of the more than 100 patients, 9 of which we knew the ethnicity. One was in Europe where apparently you're not allowed to gather the race of the patient. So we have 9 patients in whom we know what the race is. 7 of the 9 patients who were African Americans who underwent amputation. So again, this is a startling number. 20% of the patients in this trial were African American, but again, there's just an absolute disproportionate risk of amputation. Again, a hazard ratio of 13.2 when the subset of African Americans are looked at here. As you can imagine, the quality of life variables are significantly depressed given such a high amputation rate. So if we were to conclude, there's no statistical significant difference in outcomes by sex in the STRIDE study. Technical success, core lab adjudicated, of course, no difference. Target limb salvage, no difference comparing the females to males, no difference in the quality of life scores. But as we've already touched upon, African Americans had a significantly higher risk of limb amputation and a lower quality of life at 365 days. Target limb salvage was 66%, when if you compare that to the overall limb salvage rate, obviously much, much lower. We can conclude that the first-line treatment with indigo produced overall good outcomes up to 1 year in a diverse patient population, but absolutely and clearly further studies are needed to understand why we saw these differences in the African American population. Thank you very much.
Stay there for 1 sec. I made a mistake. We're supposed to discuss after each trial, so
Okay.
I'm going to have Dr. Garcia come back up if he's still in the audience, so we can talk about both of them, since there's some similar themes. You can both stay here too, both of you. But your 2 trials basically showed the opposite results, right? One trial showed no difference by race, the other showed a difference by race. Mm-hmm. What do you guys, and I don't want you to mud wrestle, but what do you guys think maybe underlies the differences, or are there any suppositions, hypotheses, anything like that?
Well, I guess I'll go first without knowing an answer here. I mean, we're looking at slightly different patient population. We're looking at acute limb ischemia versus a chronic ischemic patient. We were surprised in the STRIDE trial. I don't have a good explanation. It's clearly there, though. It's not just a few patients, but I'm left to really struggle with what that reason is, other than these are different patients upon presentation. But I think we're all sitting up here thinking that there's something more to it that we're missing. And Dr. Garcia, I don't know if you have any thoughts on that.
No, I think that we're looking at apples and oranges. I think that Life BTK was developed to look at a diverse population, and all we can say is that the scaffold worked, and it worked across all major metrics that we measured. And so I don't think that it's right or wrong to say one versus the other. I honestly believe that what we showed in Life BTK is that the scaffold works across, the little old ladies with pink shoes and small arteries, or big burly arteries. They seem to be beneficial on both sides of that. And what we were trying to prove was that you don't have to look solely at, white men in a trial, and you can actually have a much more diverse population to look for an endpoint and try to show benefit across all groups. And I think that's really the metric that we were looking at.
One thing that always comes up is the delayed time to either diagnosis or treatment, and that being a strong predictor of outcomes. I might have missed it in your talk, Alex, but was there any difference because we see this a lot, even in CLTI care, we see that underrepresented or vulnerable minorities tend to present with more advanced disease and later in their disease course, and that corresponds a little bit more to worse outcomes. I don't know, especially for ALI, that can be a factor.
Right, so that's interesting. I would argue that ALI is the differentiator that makes these patients present on a kind of a same basis here. You'd be excluded if your symptoms were greater than 14 days. But I think that we're on the theme, that maybe their tipping point presentation was at 14 days, but the actual level of disease was much more significant due to those factors that you're talking about.
And we see in STEMI also. I mean, even though STEMI should be the same thing as ALI, we still see people come in more with delayed presentations, less health literacy, they don't know what's going on, and then...
Yeah, I think that's what we're going to come down to.
And that was also shown, COVID was a perfect example of that. People just stayed out of the hospital because they didn't want to get sick, and they still stayed home with their MI. So it can happen. I mean, it's not that far-fetched.
Thank you. No, so I think even in the ALI setting, as Eric mentioned, when some of these patients don't have access to primary care, have their underlying risk factor adjusted, even when they present with ALI, they probably have had already advanced PAD, then they get the tipping point, so perhaps that could have contributed to these poor outcomes.
Yeah, I would agree. We certainly have more work to do, as I pointed out, in that demographics. 50% of patients already had undergone some sort of intervention in these legs. Whether that's disproportionate in the African American population or not, I think is worthy of further study, or definitely worthy of it.
Lawrence, there's a lot of conversation at this meeting about the next trials, whether it's mimicking Life BTK or below the knee space or moving on. You gave us a lot of great pearls on what were successful initiatives, and we're going to hear from Jay Gary also with some tips that came from the Boston Scientific Elegance Registry. Anything that stood out for you that was either novel, unique, or impactful to getting to the numbers that you did in terms of diversity?
Yeah, I think, I give full credit to the Abbott leadership. They really went after finding the underserved patient population for this trial. And then every one of those, I just found out today, I think I texted you, I just found out today that of all those metrics, everything was used as to how to get patients back and not lost to follow-up, which I think is critical. And for a patient population which almost never wants to go to a hospital or to a physician, those are all very important things. And the number one thing, as I understand it, was the gift cards. Taking the pain point of money out of going to see their physician was the number one metric that was useful for our patients. And as long as the sponsor, again to Abbott's credit, does this and does it well, it pays dividends, because now we have better science. And we have better science in a very wide swath of patients that we would not have known otherwise.
Yeah, we've talked a lot about like free Lyft or Uber rides, which are really helpful, and not paying someone back, but having that compensated up front so they don't even have to go through the process of paying. And then also those traveling ultrasound labs that come to your house if you're missing your inpatient, getting that duplex information, whether you want it or not. So
exactly.
Perfect. Thanks very much, guys. We'll move forward now.
Thank you.